Okay.
Hello, everybody. My name is Michael Kelly. I am a professor at Loyola Chicago School of Social Work. I am here with my colleague Sherry Luking, who is the leader of Midwest PBIS. And together we've been working for the last couple years looking at the role of the clinician in school-based services. And what we've learned over that time in our own practice experience and the research that we've been doing is there are some kind of key ingredients and issues that have really kind of risen to the top in terms of what people are telling us they want help with and they want to change and they see needing to change. So today we're going to talk about the last one of these four, the workload caseload dilemma, possibly, and hopefully some solutions for how we can move clinicians into being able to have a more thoughtful and realistic sense of workload and caseload. Before I dive into that, I just want to note that we are making this series available looking at a variety of topics that we think impact this changing role of a clinician that we're addressing. We've already done one on the crisis, how our jobs are often dictated in schools by this kind of drop everything and come to a crisis, and how we need to take more control over what we define as a crisis in a school, understanding that there will always be things that do rise to that level, but that many things are not in fact crises, but more a reflection of staff and administration having a limited understanding of how we do our work and what we do best and how we can maybe enhance their skills in handling things before it gets to the clinician level. Related to both of those things is the professional development idea. The more we are seen as in-house experts providing professional development and support and bringing in outside consultants as well, we raise our status as social emotional leaders in the building, but we also become viewed as people who can really build the capacity of others, which is, I think, ultimately what all of us would like to do, is to see all adults in the building able to provide support and be effective with kids on the things that we deal with. And then finally, and this will relate a lot to the workload caseload thing I'm going to start with now, this idea of a job description. Many districts either don't really have a very well fleshed out one for the school-based clinician, or if they do, it sits in some binder in the HR department and is not looked at very often, and is often not very well tied to what people actually do all day. So as we get now into workload caseload, I want you to think about all of these areas. They obviously interrelate and they connect, and think about how workload and caseload could be in some ways a mechanism to affect the others, where we could see more of a ability for us to be effective with the kids we serve and the schools we serve if we had a better handle on what workload and caseload really means. All right, here we go. So today I'm going to talk about the need to understand and define our workload versus our caseload and what the big deal is about that. We know a lot about it now in terms of how other professions have tackled this. We're beginning to learn about how school-based clinicians that work in the mental health area can do good work with this. A lot of the work that I'll be referencing today comes from other related service professionals in schools, as well as medical professionals, nurses, doctors, OT, PT, speech language paths, people that have connections to what we do but are not necessarily the school, social work, school psych, school counselor role that a lot of us are listening today. We'll get into why that's a big deal and what we do about it. We'll talk specifically about an example that I was involved in with a group of about 20 school social workers in suburban Detroit in the last couple of years, using a time study tool to look directly at what they did with their time. And there are things we'll talk about as well to even look at a broader level about how we spend our time. And we'll essentially talk about a three-step process that we think can help redefine our time as school-based clinicians. So all of us know that there are kids that have needs in schools. We came to schools as a professional. I myself was a school social worker for 14 years in the Chicago area before I went and became a professor. I loved the direct practice work. I loved being with kids in that context in my office, small groups, individual sessions, even family-based work. And that will always be, in some ways, the bread and butter of all the school-based clinicians and what we love. What we know, though, is that those kids we serve that might be in a manageable level of numbers often are surrounded by many other kids that come to us. Sometimes kids that we're not even sure why they're at our door other than someone sent them, or possibly that the school has defined our role as being the kind of go-to person for everyone. And again, I think most of us are willing to kind of work within that context as well. I know when I was in a school full-time, I appreciated being somebody that everybody knew. And I wanted that. I wanted to be visible. I wanted to be somebody that people sent kids to. I wanted kids to self-refer. I worked in the junior high, and that became a real mark of how well I was doing with a grade level when kids began to send themselves and their friends to talk to me about important stuff going on in their lives. So there's a level at which I think we can be okay with kind of being that kind of drop-in person that is seen as a resource to everybody. But this is the reality, is that most of us are in schools with this many kids, and that we can't see all those kids, and we'll never be able to see all those kids because the way we've defined school mental health in most contexts in America is essentially either a straight-up clinic-based model where we have a literal clinic in the building, kids come and see us in the same way they might come see a community-based clinician, or it is a caseload-driven model. Certainly it is in the state that I teach in, Illinois, and the Midwest PBIS is based in, that is very much driven around some of the procedures and processes related to special education. So a lot of these kids you see now on the screen would be kids that come from a caseload that is identified first with a special ed referral, a special ed process, and then given a set of mandated minutes that we see those kids. So again, a lot of those kids that we would have on a caseload could realistically maybe be in this group. But what we know is there are many other kids that come, and then we're left with all these other kids in the school that we're not really seeing at all. If we're in a caseload kind of context where what we do is driven by those X number of kids that already have an IEP for us. We know that if we can have our role be supplemented by other adults in the building, and we have other people in the building who can help us do this work, not in a way that we're trying to get out of work by any means, and there will always be work for what we do. But if we have more people around us who can do some of that prevention, tier 1, tier 2 work, fewer kids come to us with acute needs, and arguably we can be involved at those levels as well. But we know in many of our cases, the role essentially becomes us, and that's how we start to feel. So what does this add up to? I mean, again, I think all of us are in this state at any time of the year, but particularly I'm doing this recording in right after the new year. We can all be at a state of just kind of a saturation or even getting close to burnout, where we just feel like we're constantly being barraged with requests for help, as well as just the content of the kids that we're serving, what they're bringing and the difficulties they have. So we're going to need to think differently about this. There is no evidence at all anywhere that I can see in the landscape of policy and funding that they're going to be funding 10 to 15 people in a school to come and be essentially doing this casework model. Very often, most schools have one, maybe even fewer in terms of one per school. I mean, they may have 2 schools they serve. So what are we going to do about that in going forward? So I think the most obvious answer that lots of people get to, and I think a lot of people contact me and Midwest PBIS for help with, is how do we persuade those administrators to just hire more of us? They have to see the need. Look at all these kids I can't see because I'm doing this, this, and this, or all the paperwork I have to do. We haven't even talked about that. That's another piece of the load that wasn't on the last slide. We're here to say something maybe a little bit countercultural, maybe a little bit controversial. We're not at all sure that hiring another clinician is going to be the answer. I have a lot of anecdotal experience of that as a field supervisor and teacher at Loyola. Some of the schools we work in and place students in are in relatively low-income areas where there is, again, this kind of stretched kind of quality where kids or clinicians are going from, one school to the next, and maybe have 2 or 3 schools they serve. And so we have interns in school contexts like that. And then we have some other school contexts where they're an intern in a school that's got a pretty well-developed social work department. A couple of these very affluent high schools actually have a department that has 8 to 10 school social workers. And anecdotally, those people are just as busy and exhausted as the people that are going from school to school. And what that says to me, and what I think it says to the Midwest as well, is what we're essentially doing when we do that is it's a reactive response. It's not getting at the root of why we have a caseload where it is, and really why we have a workload where it is, which is we'll get into today, is something we're not even able to always talk about in a very coherent way because we don't conceptualize our work in a workload way. We definitely wish for this because we think it'll make us feel better, but as I've just shared, I mean, if we build it, they'll come. And again, if we've taught our schools that the way to get to us is to have kids at an acute level need us and or also have the kids where you drop everything and push the button and the clinician comes, it's very unlikely that our workload caseload is going to be dramatically lessened or improved by just having another clinician. So what do we need to do? We need to change the way we practice, and that's what this kind of module and really all the other modules are getting at is how do we, first of all, how do we recognize what that means for us? How do we do it within our district? And then how do we really carry it forward? And again, not to make it just on you as you listen to this today, how can you build allies and capacity to do it with others? So just a few more examples. The traditional role that we know is this idea of the plate just keeps getting higher and higher. We do interventions based on what other people have recommended. How many of us have been in a room where a kid is being discussed and there becomes this almost kind of near unanimous sense that the clinician needs to get involved, and everybody kind of starts telling you how to do what you know how to do. And then, you know, it becomes easy to get siloed. I mean, certainly in the special ed model, if you have a caseload and you do this and the speech path does this and the OT does this, it's very understandable that your time will be about what you do and not necessarily in concert with others. All the more reason we believe to get more involved at earlier stages where there can be things like a check-in, check-out, or other types of tier 2 interventions that allow you to really share the workload, but also really build the capacity of others. So the shift we're calling for is looking, and we'll get into this now, is looking at what's working and needed before adding new things. We have initiative fatigue in many districts and schools because we don't take things off plates. We don't change the way we even conceive of it. We just stack things as opposed to saying, okay, we did that, now we're going to focus on this. The idea that we would really have meaningful tier 1 and tier 2 should mean that we are using data in both of those tiers to really make decisions about what kids need next. And by doing that, we would hopefully, one, just take care of lots of the things kids need, but also not necessarily involve the clinician in the same way we typically do now, which is the break glass, bring clinician. And again, all of this is about collaborative work. So here's kind of our proposal. And again, this is not something we've invented. It's something that we have drawn from a variety of other sources. This will not be a very researchy talk today, though I can certainly amplify and supplement things with a lot of the articles and things we're basing this on. But we know that the first thing that most districts have to do if we're going to take this on seriously is look at what initiatives are already operational in their district and in their buildings. Many things are kind of happening at once. Some of them involve us, some of them don't, some of them we'd like to be involved in and we're not. We need to look at that. We need to do an inventory, and again, it needs to be done collectively with key leaders. We also need to map the interventions we already do. Some of the things we do are great, and we need to keep doing them or do more of it. Some of them, you know, we don't really know if it works or we're not even sure it does. What do we do about that? You know, how can we best use our time in that way? And then finally, we need to look at who does what and where. Do it in a way that isn't about, you know, pointing fingers or, you know, guilt tripping people or whatever kind of fears people might have around evaluation, but to essentially say, you know, here's the people we've hired, here's how many full-time staff we have in the clinician role. What do they do, and what do we want to say about that? What do we want to keep it at status quo, or do we want to shift that? And ultimately, this should be driven in a way that's a little different than we do now, which is driven by need. How we drive it now is, again, driven by caseload issues, which are often around allocation related to special ed or other mandates that come down the pike. What if we were really to define it on the needs of the building and assess that, maybe using some of the ways that we are going to talk about now? And then ultimately, this should lead to a role redefinition, where we begin to have a role that really is more intentional and more fully reflective of where you all are and hopefully your expertise. So I think you've heard me use a few of these people and considerations as we go, but just to highlight them quickly, this has to be done at a district level, we believe, first. This should not just be you sitting in your office kind of wanting everybody to understand the need to change your role or to look at your workload more thoughtfully. It needs to have stakeholders with authority. There are people out there that really don't understand what we do. That should also be said, and we need to be ready for that. We need to be ready to explain, yes, you think I do this all day long, but this is what I actually do, and I would like to look more intentionally with all the other school psychs and all the other school social workers, and I'd like to have permission to take that on this year and to work on that. Again, as you can hear, a team. This needs to not just be one person or viewed as being owned by one person. This is going to be shifting practice around roles, and you're going to need to have the role participants part of it. Ideally, I think it's important to have community partners in the process too, because one of the real issues that's going to come up when we talk about workload caseload is, well, if you're not going to do X, Y, and Z and kids still need things, where will they go? And I think there are a lot of really good community-based options that a lot of districts and communities can turn to, but that has to be done at the start. You have to involve those people at the start. So a main thing that we are very interested in is starting initially with what do we know is already happening in districts. Many districts in Illinois and certainly nationwide are very consumed with doing SEL at this point. I would argue a lot of them are also thinking a lot about school violence, bullying prevention, trauma-informed care, restorative practices. What do we know about those things? Is it connected to the mission? This is just an example from a district of how they've done it. What personnel are involved in doing these things? What are we expecting to come out of that? Do we have evidence for the outcomes? Again, this doesn't have to be purely driven by you. This could be some things that already exist in a district. But if you were to take this on and really sit with a group of people that want to look at what the initiatives are that relate to the kinds of things clinicians do, that could immediately throw up some interesting ideas about how do we look at our workload. The next thing you would want to do is look at the actual interventions that are being employed. And again, thinking about what's happening at Tier 1, Tier 2, Tier 3. My guess is for lots of districts that do this, they find that there's a lot of things that are in Tier 1 that are really curricular, that are, to the extent they are, delivered by teachers in some sort of classroom setting or an assembly or both. A lot of it may be front-loaded at the beginning of the year. What do we know about what happens at Tier 2? A lot of districts don't have a lot of really active, robust things going on at Tier 2. And if they don't, I would submit, and again, I haven't tested this empirically in a sophisticated way, but anecdotally, I can absolutely ratify that many of the schools that I see that have Tier 1 curriculum on the books and not a lot going on in Tier 2 that's really thought out and data-driven tend to have clinicians that have a really seemingly overwhelming and random caseload. So again, mapping this, and not in a judgment way, but just say, what do we know? What do we know about what's happening and why and what's going on? Ultimately, then, you would want to say, we have a district level lens of looking at how staff are utilized. And again, this will necessarily get into some uncomfortable territory because sometimes allocations for services and roles are based in kind of the midst of time and tradition. Sometimes they're political. Certain people have more pull than others, so they get to go to certain schools or have certain workloads. But it's important to get that view in a way that's fairly dispassionate, because you want to say, if this is what the district's going to provide, if they're going to give us 12 counselors and 10 social workers, and we have these needs, what would it look like if we were to actually take that on? And if we can have community-based mental health clinicians in the school and build them in more formally and more thoughtfully, what would that look like? These are the kinds of things that I think we want to encourage you to think about and to maybe build into your planning for this coming semester and coming year. So here's an example of something that I did with the Michigan school social workers I referred to earlier, where we basically said, we're not at the level of doing an initiative and intervention because these were all people in different districts, but we did want to say, what would it look like for you with the knowledge of your administrator that you were doing this to be part of a time study project with us, where you essentially kept track of your time, did it on a monthly basis, you did it online, you shared it with us, we shared it with you back, we talked about it, analyzed it a little bit, decided what to do, to bring it back to administrators and advocate for your role. And all of this was in a climate that I bet is pretty similar to where you sit today, where administrators were largely looking at your caseload. So workload is really all the stuff that's on top of the individual kids, individual mandates, individual minutes that you have. And so we didn't have in this group of school social workers in suburban Detroit, we didn't have an agreed upon idea about best practice around caseload activity, but we also didn't really have a clear idea of what workload was. Everybody kind of knew that there was something called workload, that it wasn't the same as the 20, 30, 40 kids they had on their caseload, but they weren't able to articulate that in a way that they could bring it to an advocacy level. So this is just an example of what the tool looked like. It was done, we did it for the study on an Excel spreadsheet. We've now turned it into an app that's available on schoolsocialwork.net, the site I run, for free. This was meant to get at, again, what do you do on a daily basis? You know, and we made it as detailed as we could so people could do that. People found it very feasible to use. You know, we had feasibility ratings, and by the end of it, people were all 9 out of 10 in terms of the relevance and utility of use. So here's just an example of what this looked like in a suburban Detroit context. The blue and to the right is direct practice. So that's, I should also say that the Michigan context was heavily special ed driven. So everybody, all 20 folks, and this is an average of all the folks put into one, all of the folks were really driven by a special ed caseload. There were very few people doing lots of gen ed work. As you can see, if you look at this closely, a lot of the things we talk about in three-tier work wasn't happening much at all. There was very little time average per day being spent on school-wide prevention, pre-intervention, all that stuff. So in some ways, I mean, that's in some ways disquieting, because it says that this is a role that's very entrenched in a mode that may not allow for some of the other things we're talking about in these modules. But at least for this purpose of this study, it gave us a really good look into, if people are extremely caseload, special ed, caseload driven, what does their time actually wind up being? So again, if you look at below the blue, the red, and then the green and the purple, essentially all of those, one is documentation, the purple, the dark green is crisis, and the red is indirect. All of that should be read as that is all stuff directly related to caseload kids. So my documentation is the stuff I do around those caseload kids. My crisis is when there's something going on with that kid and I'm pulled in immediately outside of my regular time I see them. And the indirect is all the stuff I'm doing to consult with teachers, parents, outside providers, etc. So what does this add up to? Essentially, depending on the practitioner, depending on the year, was a 2-year project. Essentially, you had, for every hour of direct practice, you had a whole nother almost hour and a half of practitioners saying that they were doing indirect work. So for 2 hours a day of direct practice, you have, just put the simple math here, you have basically 3.5 hours being devoted to indirect work that is in service of that kid and or crisis. So again, we talk about the crisis about crisis. This is a crisis about workload and caseload, because all of that time, as we went deeper into the work, even though it was caseload related, it was not being accounted for. It was not being included in their job description. It was not being included in their allocation. They were, if anything, feeling lots of guilt or anxiety about it, because they knew they had to do those 2 hours, but all this other stuff was counted as extra. And those things were really significant for people. There's some other details in here, and what was really important to look at was, you know, we saw that people noticed trends in the time of year. So I gave you averages over a whole school year, but basically the differences in, you know, a startup time or mid-year or end of year was real. But people didn't feel like that was accounted for either in their caseload, and people were just expected to kind of do not the same thing every day, because we all know the school-based clinicians say that every day is different, but that they were essentially expected to do things that were relatively the same in terms of their caseload, and they found that stressful. So again, here's the steps that we're recommending. We're recommending that you first get a sense of your time, right? So we're recommending, whether you use our time study tool or somebody else's, this idea of looking at your time thoughtfully and then taking that, looking at the needs of the community and the school and what's there. Here's an example of how people did that, looking at school data and community data. Again, this will be where it doesn't just get personalized over, my job's busy, I'm exhausted, I want a break, but that here's things I know are happening in my school and my community, here's what I'm doing now, here's what I'd like to be able to do more of. And we have lots of survey data, surveys I've been doing the last 10 years, that say that when you ask school-based clinicians what they'd like to do with their time, they say they'd like to do more prevention, they'd like to do more early intervention. So here's another example. People were identifying need around a very, I think, acute and important issue, which is increase in hospitalizations for suicidal ideations across the county. They wanted to have more prevention and intervention practices. They looked for ways to do that that could be co-facilitated by school and community clinicians. Now again, we know, one, beyond just the risk of harm and wanting to keep those kids safe and with us, there's also the very real possibility those kids turn into caseload kids that we spend a lot of time with at the back end anyway. So if we could be more intentional about building those relationships up front, our workload caseload could start to look different. And then I think the last piece when I think about redefining roles is we need to think about, what is already working. I mean, a change of role does not, imply or mean a complete overhaul or throw everything out. There's a lot we do that works, and we need to be proud of that, and we need to obviously show that it does work so people are able to see that more from us. But I think we need to stand on that first. Are the interventions in this continuum that we lay out of how we do services meeting the needs of students, families, and communities? And how do we know that? And are interventions culturally responsive? That's another really key piece I think we need to always be thinking about when we design our interventions. And then with this kind of intervention or initiative inventory and intervention inventory and use of time, what are we learning about that as gaps that we have? And obviously in the Michigan folks, the big gap they have is they're not able to make any time at all based on how their time is structured to do the kind of prevention stuff that actually might affect the number of kids that wind up on their caseload later. Obviously, as you've heard me say here and the other modules we'll get into as well, is there professional development that we can and should do to educate others about both what we do, but also ways they can support kind of those lower level interventions before it gets to a caseload level. And then a big part that I think is threaded through all of our conversations here is this idea of crisis, that once a kid is in a caseload mode, we have things we know to do and we will do with them, but can we do things to also decrease the amount of time we're spending in reactive crisis-based mode and things that maybe aren't really crises? So here's some just final considerations getting to sum up. I think really an important thing if we're going to change the workload caseload conversation and bring it more in line with what we actually do and really value ourselves more and get valued more. We have to really look at our interventions and use data with them and outcome assessment, because that's going to be a key piece. If we're going to look to change the way our role is defined and the way our workload is defined, we need to be able to say, I do these things get better. And again, I think we have things to stand on, and we don't have to make that up from whole cloth, but we need to be intentional about that. Looking at that current practices and time spent, as I said, sharing that with your administrator. The folks in Michigan reported very interesting conversations they had with administrators. I mean, to be honest, a few of them were like, yeah, okay, so what, I'm busy too. But most of them actually didn't have that kind of casual response and disinterested response. They were, I had no idea, tell me what you need, what can we do to look at this more thoughtfully next year. And all of that was just driven by a simple time study tool, not even some of the other things I've shown you today. A big part that I think is a focus of my own work and Midwest work is how do we make the MTSS role come alive? And MTSS isn't just a role, but it is a framework that has roles that fit nicely within it. And if we want to be seen as social emotional leaders, MTSS leaders, people promoting and developing the ISF framework, for instance, we need to be able to educate those leaders with authority in our district about what we can provide to those specific parts of the triangle and to be seen as being providers there. And a big part of that, I think, allows us to then say, and this is what my workload could be if I was doing more of that. Again, I think a very practical and tangible thing you could take from this today is to say, what if we looked at the initiatives we have and what we do and took that on, and looked at the interventions we do and took that on. And again, to take it out of making it about you and make it more about what your district can do. My guess is there's a lot of leverage points right now with all the things happening in our country in terms of school-related violence and school kind of interest in lots of things going on in school, trauma, achievement gap. There's probably a lot of leverage points you could get into. And then I'm always a big fan of involving community partners, both because we need them to do our work fully and also because they may bring things that we don't think about. And I think we can identify that continuum of interventions together. So just to sum up, working smarter, not harder is a big focus of the work that I always try to train and encourage people to do. More is not going to always be better, so just having more of us does not change really much of what we just talked about today. So what we really need to do is be able to create structures and teams and processes to at least tackle this idea of looking at our initiatives, our interventions, our time, and then begin to move to the somewhat difficult conversations, but I think they're meaningful conversations we can have to make our roles more in line with the workload we have and really make all of what we do more effective because we'll know what we're doing is more congruent. So I thank you for listening. I'm looking forward to hearing what you all take from this and do with this. And we invite you to share that with us at schoolsocialwork.net. You can reach me as well there. And we thank you on behalf of Midwest PBIS, and we'll talk to you soon.